Hi everyone, it's 9:29. We are going to make a prompt start today at 9:30. Well, it's just not turned 9:30 indeed. So it's a bright Friday morning, and so welcome to everybody. We're going to start the WebEx today. Today we're going to be looking at empowering people to be heard and helping leaders to listen as part of creating a hashtag AHP mandate. So it's a fantastic session, and thank you to everybody who's joined so far. We're looking forward to hearing more about this. So I'm just going to move on slightly. So joining in today and beyond. So if you are going to be joining the session today, please use the chat box to monitor, to contribute towards the session. We'll be monitoring that all the way through the session. Please tweet using the hashtag #EdgeTalks and the handle @School4, that's numerical for radicals, and @the Edge NHS. And send your request to join our Facebook group, School for Health and Care Radicals, the Edge and the Edge NHS. So we just really want this to be as participative as possible. So please use the Twitter, use the chat room, and for us to hear anything that you've got to say. So my name is Janet Wiseman. I'm an associate working with Horizons in NHS England. I'm going to be your chair or host today. I'll be looking after you, but also in the chat room, the technical lead is Paul Woodley. He's part of our team. He often joins us on the Edge Talk. And we've also got a special guest, which is Naomi McVeigh, and she's from Northwest AHP, and she's a workforce leader, but she also runs the We AHP community with Joe. So welcome to you, Naomi, and great to have you working as part of the team today. So our presenters, so we've got a fantastic pair of presenters today. Dr. Joanne Fillingham and Peter Hammond. Joanne Fillingham, she's a regular blogger, so I see. So I've read a couple of your blogs, Joanne, and she's from Staffordshire and Stoke-on-Trent Partnership, NHS, and she's the head of Allied Health Professionals. And she also runs the We AHP's community. So fantastic applause to you, Joanne, and we're just so excited to have you as part of the team today. But also we've got Dr. Peter Hammond, and he's the founding partner of Clever Together, and he has a wide range of interest and involvement in disruptive innovation, as well as youth development, staff engagement, environmental technology. So a fantastic background there, Peter. So we're really looking forward to hearing what the presenters have got to say today around this really important issue. So I'm going to hand over to Peter now. Here we go, Peter.
Hi. Well, to Peter and Joe. I'm
Peter and Joe.
Yeah,
Peter
I'm
Joe.
Joe's Batman. I'm Robin today.
And I don't know what I could say I am then.
You can be our Wonder Woman.
Oh, right, I'll be Wonder Woman. Great. Over to you.
So thanks very much, Janet, for that introduction, and hello to everybody joining us. It's our pleasure to be here today, isn't it, Pete?
Yeah,
and
sure.
we're privileged to be asked to come and present to you today on the Edge Talks about the work that we've been doing together. Myself in my role as clinical fellow to the Chief Allied Health Profession Officer, and with Pete's company Clever Together and his wonderful team. So that's the journey that we're going to talk to you about today, isn't it, Pete?
Yeah.
I don't know if you want to introduce yourself.
So I'm thank you for the introduction. Thanks for the opportunity. And Joe, for the record, in front of this group of people, it's been wonderful working with you. What we want to share with you today is a journey that we've been on together, and I want to share the overarching, the big takeaway, if you like, at the beginning, and then we want to share how we've gone about doing that. So in actually under 8 months, Joe held what we call 2 online workshops, and in those 2 online workshops, and we'll explain what those are shortly, we engaged the best part of 2,000 people. They shared over 16,000 ideas, comments and votes. From across the whole country, in fact, we'll share with you that people engaged from all around the world. We completed a series of countrywide visits and a series of analyses of policies, and combining the sort of triangulating all that data along with insight from 53 case studies. And effectively, Joe and the team have enabled the best part of 2,000 people to co-create a new framework for the healthcare system, and with a focus on AHPs. And someone was saying to me at a meeting, and I was at the NHS Health Alliance yesterday, and they said, in their view, we've done this 4 times quicker than normal, and at a tenth of the cost. And I think that, you know, and by having real people's voices directly at the centre of this new framework within healthcare. So we're really proud of that. And what we want to do today is share with you the journey that Joe and the team have been on, and how we'll do that today in the time we've been allotted is to follow 4 steps. The 4 steps that sort of sit at the heart of one of our key methods at Clever Together. And this is our approach to crowdsourcing, where we use an online workshop to build consensus and insight from people all over geographies. And so what we're going to do is talk about how we create, to build consensus from hundreds and hundreds of people. What we do is firstly, we define a mandate, a need to engage. What's the narrative? What's the story? And we'll spend the first quarter of the presentation explaining that journey. Next, then, when we have a mandate to engage, where great leaders genuinely want to listen to great people out there across the sector, what we do then is design a communication strategy to generate interest. So people are totally unaware of the opportunity. How do you take them from being unaware to aware? How do you take them from being then aware to considering getting involved, and then from considering getting involved to actually engage and even becoming advocates? And then when people then join the online workshop and the other channels of communications we have, how do we then turn their input into genuine insight? And there's some deep analytics that we use there to do that. And then how do you then take that insight and get into action? And so this is the structure of the methodology. So we felt it would be useful to share our journey with you through that lens. So I'm going to hand over to Joe now to talk a little bit about where the reason to have this run this project came about.
Yeah, so Pete just talked then about the 4 sections. So we're first going to concentrate on the Monday. So what was our authority to act in this instance? Well, hopefully most of you will know who's joining about, if you're in health or social or the wider care system, is about the 5-year forward view, which was published back in October 2014 and was a shared vision across many of the arm's length bodies in health and social care system. And it presented to us a number of challenges across the system, but also some potential solutions within that document. And I think it was historically in the way that it wasn't a huge document, so what I call a door stopper, which is historically what's come out of the NHS. So it's an easy readable, and it offers a blueprint for change for the future in terms of 3 gaps. So the health and well-being gap, the care and quality gap, and the finance and efficiency gap. And some solutions to that. So in terms of the need to radically upgrade in terms of prevention to prevent us continuing to spend thousands of pounds on wholly avoidable diseases. They need to get serious on quality and reducing variations in quality across the system, and to deliver new models of care, so very different ways of delivering healthcare across the system, and also keeping our eye on the money, taxpayers' money. So that's where the national policy obviously came from. We know that off the back of the 5-year forward view, there was the Vanguard programme in NHS England, particularly to address the new models of care. And there were 5 types of models. And if you go to the NHS England website, this map's on there, and you'll be able to see in your local area where those new models are. There are 5 types. So multi-speciality community provider model, the primary and acute care systems, acute care collaborations, enhanced care in care homes, and urgent and emergency care. So go and have a look at those.
Put yourself on the spot then, didn't you?
Yeah. So Suzanne Mastick, who's the Chief Allied Health Professions Officer, who I was reporting to in my clinical fellow role. As part of her role, she visited many different organisations in 2015, 2016. Obviously, this is following the publication of the 5-year forward view and the commencement of the new models of care. And without doubt, wherever she visited, both from clinicians on the ground up to senior leaders, she was asked, what is the vision for allied health professions in this system? How can we utilise their resource to best effect to be able to deliver the change that we need and the health and care systems for the future? And undoubtedly, everywhere she visited, that's what she asked. I think one of the things that we were challenged about was to whether we should have a combined strategy. So the nurse strategy was developed around the same time at the Leading Change Adding Value, and there was some discussion over whether we should have a joint strategy. But it was really felt that allied health professions have never had a strategy before, and that we absolutely crucially needed to hear their voice in the system about what it is that they do really fantastic now and what it is that they can harness in terms of that to develop new ways of working in the future. So I discussed about the 3 challenges that are faced and some of the solutions to those, and those are outlined in the 5-year forward view. But in particular, what we wanted to ask AHPs, and Suzanne in her visits, and myself, and also the Deputy Chief Allied Health Professions Officer, Sheila Morris, when we were out visiting, is we were challenging AHPs to say, you know, in terms of the care and quality gap, what do AHPs do for people, for the person? What do we do for populations, for communities? And how do we evidence that we deliver quality, but also produce efficiency? So these are some of the challenges that we were posing to the system when we were presenting over that period of time during 2015 and 2016.
So you've set this context, Jo.
Yeah.
Right? Suzanne, there'll be people on this list here, right, who don't know Suzanne, and there'll be people who do know Suzanne.
Yeah.
She's in a position where she's the Chief Allied Health Professions Officer for England, right, which is a pretty massive role. I've got the privilege of working with some pretty senior people across the system, and I know you do too. I think she's pretty unique in the sense that as a leader, she felt that to rise to the challenge that you just talked about, she had to really genuinely listen to as many voices as possible.
Absolutely, without doubt. We both her core values as a leader, myself and Sheila, we really felt that we had to listen not only to AHPs on the ground, because we truly believed that they had the answer to these questions that we were posing, because we were hearing those answers when we were out in the field and we were presenting. But not only listen to them, but to listen to the wider system, and that includes patients, service users, the community.
Exactly.
If we were to truly develop a strategy that was fit for purpose for the future.
Yeah, yeah. And so this little picture you see on this page here now, this is in fact that picture was in this room that Jo and I are sat in right now. So we had most of the chief officers of most of the professional bodies of AHPs. They came together and we ran a workshop with them. And Suzanne, and that little pitch there is most of them. I can see people like Kamini and others in there from Jerry, from
Richard Evans.
Yeah, Richard, the whole lot. And so they all came here. And Suzanne talked through this journey that she's been on, literally around the country, and they talked about their journeys about this too. And there was a shared agreement really that there could be gains made for all AHPs and the health and care system if we kind of orientated around some common goals and common challenges together. And what was really interesting, we'd done some background research on each of these professional bodies, and we could see that there were some common goals emerging as well. And there didn't feel in this room when we discussed it there was a need for a shared strategy for AHPs because there's such diversity in that group. Yeah. But they did feel that there was if you had a national conversation about what could our collective impact be, we could define something really special. And in that room, those leaders, they genuinely believed that they had sat on the evidence that if we could pull in the same direction, AHPs could have a collective impact that's genuinely transformational for the health and care system. And so what would that impact be? What would we need to start to do differently to have that impact? And are there examples out there that are already happening? Because the room was full of people, the room was full saying, well, this is happening in Stoke, and this is happening in Manchester, and this is, so there's already great stuff happening, but how do we shine a spotlight on that? Yeah. So this was the task, this was the mandate, if you like, that popped out of this process. And I think really the room agreed that there was a need to assert and demonstrate the transformative potential of AHPs, like I've just described, but also it was really to provide leaders of the system with a real, to inform them and inspire them with a framework, if you like, a clear view of what the transformative potential of AHPs is, but also what examples that are out there that they can scale and exploit, but in an evidence-based way, not just a kind of let's stick a nice case study online because I think it's nice, but what's the evidence behind that? And then have a framework to then help look at local delivery plans and say, well, how can we more effectively use AHPs? So that was the mandate, that was the challenge that was thrown down, and Suzanne, in her bravery with you, sort of said, well, actually, we bet AHPs nationally know the answers to these questions. So that was the task we set out, right?
Absolutely. And we knew from our visits that AHPs did have the answers. We knew that in our heart of hearts, because we were having those conversations out in the field. We were having those conversations when we posed those questions about what do we do for the person, what do we do for populations, how do we maintain quality while also sustaining finances. AHPs had the answers to those questions. If only we could just collectively pull all that together, it would have been really powerful.
Exactly. And what was really interesting, and I'm maybe being controversial here, right, that a lot of leaders we come across typically feel that what they've got to do when they've got these kinds of big questions, that they've got to bring in a team of analysts and use their brains, use this small group of people to solve the problem, and then tell everyone this is how we're going to fix it. But Suzanne and yourself and Sheila were brave enough to say, well, actually, let's flip this round. If we're really going to achieve these two things, assert and demonstrate transformative potential, and provide a platform that can inform and inspire leaders and decision makers, then we've got to do things differently. So this conversation came up in that workshop as well about crowdsourcing. And for us, that's a process of really how do you empower lots of people to solve problems and fast in a really smart way. And the second thing, that you can't just sort of listen to the voices of lots of individuals, because you want to make sure you've not got mob. You want to crowdsource, not mob rule, right? And so we also agreed that this working differently needed crowdsourcing plus policy analysis plus leadership engagement. And so this was so we had a mandate and an agreed method, if you like, to interact. And really, why crowdsourcing? Well, the obvious reasons, as it says in the slide here, was about we want to engage more people in less time. There's a load of people who are geographically constrained. They can't get to workshops, or don't have the time to get to workshops. So you can join an online process and also massively reduce engagement costs and reduce the innovation cycle time. And by that, what we mean is that you can have a conversation, analyze the data, come up with solutions, and validate those much faster using these kinds of methods.
And when I first met Pete and we talked about these digital platforms, I got so excited following some of the work that I'd done in Midlands, where I'd done some kind of face-to-face workshops, kind of crowdsourcing in a face-to-face sense. I can absolutely see the huge potential that a digital platform could bring to this. Because as Pete said, busy clinicians don't have time to get to a workshop. Sometimes they're not allowed to get to workshops because of a day job. And so this, to me, seemed like an absolutely beautiful solution to ensuring that people got their voice heard. I think our lights have gone off.
The lights have gone off because they've been so motionless in the rooms. We've got an energy-sensitive office. Hang on.
Okay. So
I've got an idea, Joe.
Yes.
Right. So the next bit here we want to share with you. So you hope you get a sense that when we decide to engage here, we didn't just kind of go, let's send a question to loads of people and come up with your question really fast, right? What we did is we analysed policy, we spoke to leaders, we understood the big mega trends. We really built a consensus of leaders that said they want to hear the voice of people. And we work really hard to work out a narrative, a really clear narrative of why there's a need to engage, what the promise will be, and what the outcomes look like, you know, or not what the outcomes look like, what the aspirant, what we aspire to achieve, the end goal, right? And so in that basis, that piece of work around defining your mandate is the most critical part of any process when you come to crowdsourcing, or when it comes to helping. If great leaders genuinely want to listen to their great people, defining the mandate is absolutely critical. It's the piece of the puzzle that always gets overlooked, and it's hard work.
Yeah.
You've got sometimes that's political. It's a real challenge. The next step then is then saying, well, now we've got this mandate, what's the target population we want to talk to? How do we get them interested? So before we tell you about that, we've got a little thing we want to do with you, which is we know exactly who took part in our process. We know them to the individual, but what we want to do is find out a little bit more about our audience. So in a similar way. So what we're going to do is ask you all to just fill out a little short survey that's on this platform now. So hopefully it's going to work. Neither Joe or I have done this before, so fingers crossed. We start this. Let's see how we go. I think there's a little button here that should just say start, isn't there? Is it this one?
Hi, Peter.
Hiya.
If you've got the poll window open,
yeah,
it should be down in the bottom left of the screen.
Open poll.
There you go. That's it.
Paul, you're a legend as ever. So
I
is that
do
running?
my best.
Yeah, brilliant, brilliant.
So it's open for 5 minutes.
Yeah, yeah. And what
that'll run for full 5 minutes for you.
Yeah.
Now.
So all of those people who have been so wonderfully kind to give us a little bit of their time today, could you look at that poll now? I don't know how it looks on your screens, but there should be some questions now that appear on your screen. People have started answering. Look at that. The nurses were first. Yeah. Well, the AHPs are now winning. But we expected a bigger AHP audience. That's great. So if you can start to answer those questions, and we're asking about where you come from, what role you've got. We're asking, we're asking a little bit about your age and a little bit about your demographics. And so whilst you're filling that, whilst you're filling that out, we can see that a fair number of you have already done that. That's brilliant. Thank you. 59% of you have already completed it. And what we'll do is we'll tell you a little bit about how we generated interest. Joe.
So as Pete said, we wanted to make sure that people understood what we were trying to achieve, and that we wanted to excite people in terms of saying we genuinely want to listen, and we want you to come to the platform, and we want to hear your views. So we did that by designing a communications campaign in which we utilised both social media and historical ways of communicating via email, and also continuing in our visits across the country, both Sheila, Suzanne and I, and also the AHP regional leads were also part and parcel of that communications campaign, and were absolutely crucial, and you'll see in a moment why they were crucial in terms of those regional leads and the networks. And also the thank you, Pete, the communication leads from each of the professional bodies, again, were crucial in terms of getting the message out to their members. And we had various other modes of communicating. A number of other organisations, NHS employers, for example, were also commandeered into getting the message out. So various different methods in terms of ensuring that people were both inspired, informed, and knew what was happening in terms of the plan, the end goal in mind, and how they could contribute to that.
And I think critical to this communications campaign is not only a multi-channel approach to raising awareness, but because you've written a mandate, a narrative of why you were engaging, what the desired outcomes will look like. It gives you the ability then to communicate in a powerful way. Yeah. And I think, again, it comes back to this, it's really clear you wanted to engage as many AHPs as possible, and also the associated networks, and then start to reach out to patient networks too, yeah, and public networks. And so you had a really clear communication channel because you put the work into the mandate.
Yeah. I think the other thing to say about that, Pete, as well, that wasn't without challenge.
No.
So we were challenged with the fact of, you know, I guess there were two major challenges. The first challenge was about, well, when you listen and hear what people are going to say, you're going to have to act on that. Well, yes, that was our intention. So convincing people that that was the case, that actually this wasn't going to be a tick box exercise, was a challenge, but also an opportunity to say, you know, we're truly going to listen and act. And the other, I guess, challenge we had was about the co-production with patient service users and the community. You know, the challenge was that, well, to have those people involved in this type of program and this type of platform, we'd have to do a lot of work upskilling patients and service users to be able to be involved. Yeah. And we pushed back on that to say, I'm not sure that we would need to, that, you know, these people have experience, a different experience, but a crucial experience to bring to this process. Absolutely,
absolutely. And with that, I think the interesting thing about this is that Suzanne and yourself and Sheila and the team that formed around, you wanted to be held to account, which is why you use this method.
Yeah.
If you don't want to be held to account, there's methods that you can use where you can kind of hide the news that you don't want to hear.
Yeah.
But you wanted to hear the real voice.
Yeah. This was open.
Yeah. So this is an example of one of the kind of images that was used. But more interestingly, so you know, how we generated interest. This is where the people came from, right?
Yeah, so when people came to the platform, we asked them, how did you hear about coming to this platform? And as you can see here, what I said earlier is that the AHP networks were really crucial. So there were a large percentage of people had heard about the platform through the AHP networks. And then the second largest was through their own organisation. And I suspect that the message went down through the AHP networks and then down through the organisations. So we could clearly see how powerful those networks were and how crucial the AHP regional leads were to that, to ensure that we had communications channels down and back up. I think what's also really interesting to note, which we'll come back to later, is that in terms of the platform, you can start with a baseline of email addresses. So we started with approximately about 300 email addresses, of which when the platform opened, we emailed out to them to offer them a username and password. And then over and above that, people can either be invited to the platform, they can be nominated by other colleagues, or people just coming to the platform can ask for a username and password themselves. But I think it's really interesting that we actually started with only 300 emails, but actually ended up with far more people.
Yeah. And again, for me, if I reflect upon this compared to other experiences, it does show the power of existing AHP networks and the influence in collaboration there of the professional bodies as well. You know, and I think, you know, that typically lots of people think, well, if you're going to build a crowd, social media is the way, or email lists. But actually, there's networks of networks. Yeah. And I think this is about, you know, it just shows we've built a crowd here of people by leveraging networks of networks. Absolutely. And I don't think other professional groups quite have such networks that are so committed in the way that the AHP networks are. I think it's really interesting level of connectedness in that. But that's maybe a hypothesis we can test another time. In terms of from where they came from, well, this is interesting, right? Because this is a national conversation. Yeah. And this our platform, you know, although all contributions on our platform are anonymised, it takes a little snapshot of where people are logging in from, as do most websites. But we publish ours, and you can see at first people were logging in from all over the UK, and you zoom out from that, and actually we were giving voice to AHPs wherever they were around the world, right?
Yeah, absolutely.
How did that feel when you and Suzanne and the team were looking at it?
I just couldn't believe that those red blobs were coming up across the whole map. I was like, really? And Pete always makes me laugh, is when Pete presents, he always says how committed AHPs are, that they logged in when they were on holiday. You know, I suspect some of these might be AHPs.
No, I know for certain there's at least one of those blobs from Canada. Because the person rang me and said, I logged in and I saw a blob appear in Canada. But anyway.
No, but in seriousness, we did receive through this process emails from healthcare providers and senior leaders internationally about the process that we were going through. So that's quite interesting that we did have that interest internationally.
So this is how we generate insight, and we've got insight from generated interest, and we can see that we engage a national audience and people who are based overseas, but also people who are from the UK whilst they're overseas. And again, it comes back to this whole thing of, we could have run a series of workshops here, face to face, but that would have been slower. It would have cost a lot more. And if people there's a limited number of people you can fit in a room where we have no limits on this. And because we opened the conversation in 3-4 week blocks, it meant that people could join in whenever they want, however they wanted, at a time that suited them. Yeah. And I think that it's basically creating a much more human-centered approach to having a dialogue. And so we'll talk about who took part in more detail in a minute with the what's it called, with the on the online platform. But we can see today that we've got 40% of you who are on this WebEx now are AHPs. We've got, what's that, 7% who refer to themselves as administrators, 7% nurses. We've got I don't know what else here. We've got project managers, patient service users, 7%. Hello, patient service users. Wonderful to have you here. And then there's 33% count themselves as other. In terms of regions, we've got the North, the Midlands, national represented here, and non-UK. Welcome to those outside the UK. In terms of age range, we've got we've got a good spread here. That's great. Yeah, 20% of us are over 55, and we've got 70%, nearly 80% of people who are female versus male, and that's something interesting about the AHP space as well. I don't think I've ever been to so many meetings where I've been the only man in the room, but that's another conversation for another time. So now, how do we generate insight? So this is the concept of taking inputs from hundreds and hundreds of people and turning that input into genuine insight. But before we do that, is it worth pausing for a moment to see if there's any questions coming up on the?
Yes, on this platform, on social media.
So Paul, Kate, or Janet, is there anything you want to highlight that people are talking about at the moment?
There haven't been any questions coming through on the chat yet. I think it's been resonating what you've been talking about. People particularly liked your conversational approach at the start of the session. They like that. It made it feel very welcoming and warm.
Oh, good. Good.
Yes,
well, that's part of the ethos, right?
Yeah.
Exactly. And the references to the other networks, such as the care homes, has made people feel included. They like the fact you're referring to, rather than just the core performers you had, that's the way that you've had the engagement from other areas has made it feel a broader programme. And a few people have asked to see your poll results, if you're happy to share them.
Yeah.
Yeah,
always
if
transparent with data.
There we go. If you look at the polling at the bottom left, just above where you've got the clearing button, you've got an option to share results, share with attendees, and you can share the poll results. Attendees that way, so everyone can see it. It's a little square box for you to tick.
So it's poll results.
Yeah, if you click on that. Yeah, that's it. Everyone should be able to see that now. So.
Ta-da!
That's brilliant. Can we go to Naomi before we go ahead? Can we go to Naomi?
Please do.
Is Naomi there?
Yeah, should be now.
Hey, Naomi.
Morning.
Morning.
Well, no questions from Twitter so far. Quite a few tweets, mostly from WeHPs and the Edge, and Sally's been tweeting too this morning. I'm not sure if Sally's there online. And one of the things I was going to comment on, Pete, was you talked about AHP networks and that being strong for other professions. I think you're right. I think we're really lucky to have quite some well-established AHP networks around the country. I think here in the Northwest we're really lucky. We do have some other professional networks with pharmacy, psychological professions, but absolutely there's that real strength and value, I think, around those wider regional networks for AHPs.
Yeah, you're very humble in saying you're very lucky to have these networks. I think the AHPs are lucky to have people like yourself, Naomi, and Joe, who drive and support and nurture and these networks and help them flourish. I think you say you're lucky, but it takes a lot of effort. And yeah, I think there's a lot of work that you do as a team that others around the country could replicate, frankly. Forgive me for maybe, I don't mean to make you blush, but it's true, right? It's true.
We'll have to say we're very fortunate here in the Northwest because Health Education England has supported us in terms of resource as well, and that makes such an amazing difference. Anyway, sorry, I'm going off on a tangent.
No, you're right. No, it's good. Good stuff. So should we crack on with the next part then, and we'll come back because there's probably going to be raising some questions out of this next bit, I think.
Yeah.
So we're going to talk to you about how we generated insights, and what we'll do a little bit here is tell you a little bit about the platform itself, give you some stats and facts about what happened and when, and then how we've actually analysed the data. Shall I do this bit? You do the
No, I'll do this. Yeah.
Okay, great.
Yeah, no, I'll do this. And so here on the screen, you can see a screenshot of what the platform looked like when we opened up for phase 1. So we had 2 phases. And the first phase was absolutely about generating that insight, and it was a tailor-made online destination for delivering our end goal in mind. And we had 2 key questions really that we wanted AHPs to answer, and you can see those under defining our potential and realising our potential. They were, how will England be different if all AHPs were genuinely used effectively? And what do you think AHPs need to stop, start or do differently to ensure they are used effectively to transform health and wellbeing in England? Please say how and why. So those were the 2 really key questions that we wanted people to come and have their voice and have their say. But more crucially is that we wanted people to share their successes and their innovative ways of delivering services or case examples. And that was crucially that third part of gathering that innovation, AHP innovation. Yeah. What you can see on this platform is where you can people can post their ideas. So there's a little light bulb there underneath the question. You can see how many ideas people have posted. People can comment on those ideas, so you can see the little speech bubble there and how many comments have been made on those ideas. And people can vote whether they like or dislike either an idea or a comment. And people just love that voting. I think we're just so used to Facebook, aren't we? It's really interesting. You also get to dislike. But what I was going to say, which people are really interested in, is AHPs are so nice that I think for the first 3 or 4 days we noticed that nobody disliked anything at all.
Yeah, and absence of the votes was almost seen as, well, we don't like that. It's like, come on, people, get the thumbs down.
But as soon as a few dislikes went in, everybody was like, oh, I can dislike, it's okay to dislike.
It gives permission, right? I think what we're trying to do. This whole method is about creating a safe environment for people to share their authenticity.
Yeah.
Right? And that, you're right. Once someone did it, people felt permission, right?
Yeah.
And so there's 3 things I want to just point out about that platform and what we're just talking about here. One is, I'm sure those of you who have logged onto a WebEx, most of you are going to be reasonably technologically savvy, I would have thought, because WebEx isn't always the smoothest of platforms to use at all times, but it's a great platform for what it does. Our technology for the NHS is, you look at this screenshot, it does not look beautifully sophisticated, but it's designed like that on purpose.
Yeah.
And so we actually designed this platform. We co-created the look and feel of it, exactly where the buttons are, what they do, with 50 ambulance drivers and it's either 50 or 75 health visitors. I can't remember now. And we chose those 2 sectors of the NHS because our research showed that they were some of the least digitally literate people in the system. So we could sit with them and say, well, where would you put this and how does that work? And we did some ethnographic approaches to designing this the way it looks. And we also then tested at this platform then along with other types of technologies, because we used to be a lot more technology agnostic and just use other people's platforms for these kinds of approaches. But what we found was that they're deeply complex. And so that it's like technology designed for technologists. Yeah. Beautiful singing, all dancing, graphics everywhere, everything else. And we saw that the more complex or supposedly technologically beautifully looking the platform was, the less people, right, it created a barrier to those who are less digitally literate. So this is why it's designed in this way. And our platforms for outside of the NHS in, say, banking or law, they look quite different because it's quite a different feel. And we sometimes get asked, well, can you not make this more whizzy and bangy? Zhuzh it up. Yeah. Zhuzh it up. But we don't, because we know we've A/B tested this in so many audiences that you know that it's really important. And I'm labouring this because this is we said we were going to demonstrate how we did this. The point here I'm making is that technology in this instance, with our whole methodology, is the easiest part of the process. Writing the mandate, getting people interested, facilitating the process, analysing the data, that's all the hard stuff. Technology is the easy bit, but don't fall, if you're going to do this yourselves, don't make the mistake of getting some piece of technology and thinking the technology is the solution. It's not. It's a tool, and you need the simplest tool possible. And the other thing to highlight in this is that Joe and other people in the network didn't just let people share ideas and get on with it. You were actively facilitating. So if someone put an idea on there that didn't make sense, or you wanted more clarity, you would go on and make comments saying, "Can you?" Conversation. Right. And so exactly. So it's not a survey. It's not a cold, calculated. Let's see what statistical differences there are between these groups. It's a conversation. Although we do have data in the background which we can run through stats. So I just wanted to highlight that too. It's a facilitated process, which is why we call it an online workshop. Because if you think about it as a workshop, you end up being a lot more conversational and facilitative than cold and calculated.
And actually, some of the feedback we had was that people found it a really great CPD. Because they were having conversations. Really powerful stuff.
Right, anyway, let's move on. Conscious of time.
So just a little bit of data for you, and we'll probably whiz through these because we're conscious of time, but I think these are really interesting. So this shows over the time period of that first phase how many logins we had. So you can see it was over 3 weeks. You can see that at the weekends people didn't really log in, so they tended to log in on Monday to Friday. And you can see in that last week there, on the last day, everybody really wanted to have their say, so lots of people logged in.
That's what's interesting is that you can see when you sent out communications. So you invited people at the beginning. The sort of 3 uplifts are when you then sent facilitation communications.
Absolutely.
And people came back to the platform to get involved.
So this graph now shows, if you remember on the platform, you could post ideas or comments. So the blue line is how many ideas were posted over that time period, and the red is how many comments were made on those ideas over that time period. And again, you can see over the weekend, the activity dropped. So people were coming to and having their say during the week in the main. But look at that on the last day. People really, really wanted to get their last say in. That's really interesting.
Right,
And this is that like or dislike button. So how many people were voting again over that time period? And look at that last day, how many people were doing their likes, dislike,
Absolutely. And again, the 3 peaks before the big end phase, it falls in line with when you're doing the facilitation communication.
So, so we had that first phase of generating insights. We after that first phase, we did an initial thematic analysis of that data, and oh, sorry, I'm jumping ahead here. Sorry, I'm looking at the second phase. Sorry, keep on with the first phase. So who took part in that first phase? Here's a graph that's just showing all the participants. What it shows is the red line shows percentage of AHP to a HCPC registrants versus the percentage of that profession who engaged in the online workshop. And what we wanted to try and do is look at whether we had a representative sample coming onto the platform. So let's move on to the next one. What we saw was that some of the smaller professions were really, really keen to have their voice heard. So you can see there, speech and language therapist, dietitian, orthoptist, art, music and drama therapists were a higher percentage who came to the platform versus that percentage in terms of HCPC registrants. But what we also saw was that some of the other smaller professions, we didn't feel that they were having a sufficient voice heard, so there were fewer of those coming to the platform than what were HCPC percentage participants. That's one of the reasons why we opened for a 3rd week. So initially we were just going to open the platform for 2 weeks. And in that 3rd week, we did more communication engagement with those specific professions. And definitely their voice came through in a third week. And we really then saw in that third week a data saturation point where there were no new ideas or new themes coming to the platform. So we felt very comfortable to close that third
and
week.
no new things coming from those populations. So they were repeating what had been said by others. So we felt that we captured the point. I think that's really important. Two things you raised there are really important. Again, other people want to run this kind of process. Is one, understanding who's actually taking part, because you said you wanted to target everyone, all professions, so we can categorically say all professions have taken part. We know they have, and we've got a broad sample of those people across the whole of the UK, broad sample of ages. The target population of professionals who took part maps the target population of the country, right?
Yes.
So in that sense, there's a kind of, although it's a qualitative piece of work, there is statistical semblance there between the two populations. And the other part is data saturation. Even in the smaller groups that took less, engaged less, what we can see is that when they were engaging, they were saying the same, stuff had been said. So we've reached that saturation. So these are two analytical methods of understanding the data and the process to make sure we genuinely are listening to the right people.
And what's really fascinating actually is paramedics look like a smaller percentage. Actually, if you read some of the contributions on the platform, that their voice really came through very strongly.
A lot of the ideas are really liked, weren't they?
Yeah.
Definitely.
So we talked about thematic analysis. So Pete's team supported myself and trained me in their methodology. So I carried out that thematic analysis, read every single contribution, which I felt very privileged and proud to be able to do that.
Yeah.
And you truly take on, Pete and Pete's team said, you take on the voice of the crowd, and I really felt that I was doing that, and Pete saw that happening. What we also did for some quality assurance is 5 of the regional AHP leads also supported me in looking at the coding in terms of those themes, and there was 94% agreement, and with 6% of that outstanding, then we reanalysed and recoded those. So a process there for ensuring that we not only had the right themes, but that other people confirmed that was so.
Yeah, and I think just a point to raise there is that typically when people use crowdsourcing methods, if you've not used this before, it's often seen as, well, whatever the crowd promotes to the top is the best idea. That's just not true. It's a conversation, and so what the thematic analysis does is it categorizes all the ideas and comments into a series of common themes, of which then you can unpick and get deep dive into to create a kind of what we call a shared narrative. And then we can when we've got these core themes, then we can look at the voting inside the ideas and then say, well, actually, although this theme over here it may have less ideas, there's some weak signals inside there. Yeah. So if you're a qual research geek like me and my team are, and like we've become one of our geeks, right? But it's fascinating. Yeah, like you get a real. So if you'd just listened to the stuff that's been voted to the top, it would be 1 million times less rich. Yeah. So it's doing the analytics. It's absolutely critical. Yeah. And luckily, you're a smart woman, so you kind of just picked it up real quick. But it's hard graft, right? Yeah.
So at that first phase, our lights are going off again. We ended up with some high-level themes, which were 4 ways that AHPs will impact the health and wider care system, 4 areas of commitment of which they're committed to delivering services now AHPs and need to continue to do that for the future, and 4 themes of which AHPs need to focus on or prioritise to enable them to deliver the impact and the commitments. What we were able to do is look at those commitments and priorities and kind of against each other, which enabled us to have the 16 enablers, some questions for the system to enable to deliver on those priorities and commitments. And as I was jumping ahead before, is that at the Chief Allied Health Professionals Officers Conference on the 23rd of June, we presented that emerging mandate back to the crowd there. We also thanked them, well, Suzanne Rastrick thanked them, and we thanked them when we presented there about the amazing engagement from AHPs. 1,360 people took part with over 10,000 contributions in just that first phase, 3 weeks, which I think is really amazing. Yeah. So this is the emerging mandate that we presented at that conference at that time. So you can see there the 4 areas of commitment. Along the bottom, underneath the bottom arrow, is the 4 areas of focus or priorities. And in the big purpley red circle is the 4 areas of impact.
And these slides will be, we can send these slides to anyone who's got it. Brilliant. Okay. So the bit here for me, which was really interesting, was Joe had done this massive piece of work. All these people engaged. Suzanne presents the voice of the crowd to the conference, and then we had some really great feedback. So firstly, this was quite a nice piece of feedback.
It just gives me goosebumps. I think I always present this slide in terms of saying we often get challenged to ask what's the definition of an AHP. There isn't one. I'm not sure there needs to be one or should be one because they're so diverse. But actually, I think this really comes close to being, if we needed a definition of what AHPs do, not in totality, but captures some of that. So I think this is a really beautiful quote that's taken from the platform. And of course, all contributions are anonymous, so we can't tell you who this came from.
No. And then at the conference, Suzanne then announced that she wanted that she wasn't just going to stop there, and Joe wasn't going to just stop there, and Sheila and the team weren't going to just stop there. Actually, what we wanted to do was the results that had come out of the analytics, we wanted them to take back out to the crowd to say, well, look, we've analysed your voice. You've co-created, effectively, our analytics of your conversation has created this framework.
Yeah.
But we want to make sure we're right.
Right.
And so we want to know what's wrong, what's strong, how can we improve it. And so phase 2 of the conversation was then launched, and as you can see on this slide, hopefully, what you can see is that we've shared you can see now AHP impacts, AHP commitments, AHP's focus, and you can see it's got 4 ideas, 4 ideas, 4 ideas. These are the 4
emerging themes.
There's 4 emerging themes for each, and we switched off at this point the ability to submit new ideas, and switched on the crowd's ability to then comment and vote and share votes on those comments. So we can get a real rich understanding of how much the crowd liked or didn't like, the terms used, the conclusions reached, that kind of thing, right? Yeah.
So again, we just wanted to share with you a bit of the data because that's really interesting for us. So it was a 2-week period, that phase 2, and here again you can see the log-on. So people were really keen to come and have a look when we opened, and then again in the second week on the Monday. But unlike the first phase, obviously this appeared to tailor off. So we again really felt that we were again at a data saturation point, that people were comfortable that they had their say. This slide shows the comments. As Pete said, we closed off the ideas function because the ideas were the emerging themes, and this shows how many comments people were submitting to the platform. And here again, here are the votes. Again, interestingly, on each of the Mondays there, people were really keen to come and do their likes or dislikes to that phase. But again, those tailored off towards the second week.
And I think the interesting bit here for me is that so the process we use there is what we call at Clever Together a strategy validation process. So we have clients where the team has developed a strategy. They then take that strategy out to their workforce and say what's wrong, what's strong, how do we improve it. And so you and Suzanne use that methodology to then take that conversation out to the people. I thought, and also when people like an idea or like a comment, it's a bit like in a physical workshop where people in different parts of a room may have written the same comment on a post-it note. And if you then analyse all those post-it notes, this is why the platforms can make it faster and more transparent. Again, I guess.
Yeah.
And then
you're familiar to the last table. Another column in it. So the red is the HCPC registrants. The green is who took that from phase 1, and the blue is the data from phase 1 and 2. So the total of that percentage who came to the platform. I always point out the OTs definitely made a big impact in the second phase because their blue line there goes right off the scale.
Do you think that's because they're a bit more reflective?
Possibly.
We'll explore that another
and
time.
then there you can see how many other professions came to the platform and patient service users. What I became a little bit disheartened at the numbers of patient service users who came to the platform. But actually, when you look at the blank or other, so this wasn't a mandated field. People didn't have to say which profession they came from. Actually, we got quite a high percentage in blank other, and I suspect that some of that might have been patient service users, because again, the voice on the cloud came through really, really strong. And I think that the next slide shows one of the quotes from a patient, obviously, and that voice was so strong that I felt confident, even though we didn't have the figures, that we had that engagement from patients and service users. So at the end of both phases, we had 1,949 people engage. We actually, in terms of people who were invited to the platform, it was nearly 4,000 people. Yeah. So that's what you can see from the platform. So people came but didn't engage, but the people who did engage were 1,949.
So just to put that in context, it's a bit like if you run a workshop, you have 100 people in a room. Typically, maybe 20 people will talk. You know, the other 80 people are reasonably quiet, and of the other 80 people, half of those, maybe a quarter of those, might put that. You might get a little bit engaged, and the others are they're almost observers. Well, this is what it's like in an online environment too. So we engage directly this many people, but twice as much we're observing and watching, without doubt.
And 16,000 contributions. So we want to say thank you to everybody.
Yeah.
This is a quote from the conference, actually, from somebody in the audience of the conference who was just really excited about the methodology, and we just wanted to share that with you. So the final bit is about the action. So this is kind of what's the next step? What does all this come to? What are we going to do with this? Well, the next step is that, and this will be the first time people have seen this, is that all this has ended up in a product. So this is the end point in mind, in which we had this mandate, we had an authority to act.
Please hold.
To listen to AHPs. And to develop a vision for the future, to inform and inspire the system about how AHPs are vital to that system for the future. And the product is Allied Health Professions into Action, which will be launched in the new year in January. So I'm conscious of time, but we're just going to quickly show you a couple of slides about what that product looks like. So the product is going to be in two parts. Part one is about those impacts, so the impacts of effective and efficient use of AHPs for people and populations. And of each of those impacts, there are case studies which shows innovative AHP solutions delivering on those impacts. And part two is where we utilise the commitments and the priorities from the emerging themes from the conversations. And as I said, that what we've developed is a framework. I mentioned those 16 enablers, so there are 16 questions that are posed to the system, of which could be used as a self-assessment to look at how do we utilise AHPs to best effect in the system. It sets out clear responsibilities, both for the Chief of Service in NHS England, for system leaders, and for AHPs themselves. And as I said, it poses questions to those leaders within that framework in part two, using the commitments and priorities, and really challenges them to think about the utilisation of AHPs when they're developing plans and strategies. And this product is for everybody to consider: boards, SCP leaders, higher education institutes, academics, is to utilise this product when they're reviewing or developing frameworks or plans to look at the utilisation of AHPs and how they can identify best practice and look at any gaps that need action.
in some ways, we wanted to sit with you today and share with you more about that report and the action that's coming out. But the report's going to be released in January, I think, because in part because of the NHS communications time cycles and other such stuff, right?
Yeah.
So we're sort of we wanted to tell you a little bit more about this next step around action. But I think what Joe just pointed out is that there's a really powerful report here and a framework that has been co-created by hundreds and hundreds and hundreds of professionals, service and service users, where that framework is the voice of those people, triangulated with policy and system leaders' views too, to then help system leaders really sort of challenge themselves and think about how they can use the power of AHPs. So this is really helping also shine a spotlight on examples of innovative practice, but it's the voice of the people that's going to be able to help leaders make that next step in their thinking about AHPs and to develop and to hold those leaders to account. And so this is we can't find anywhere where this has really been done before. And so it's a really great example of how great leaders have really worked hard to listen to great people across the system to move a whole profession or professional groups forward.
Yeah, absolutely. And I can't wait to see how the next stage unfolds in terms of the interaction.
Yeah, we've got some plans, we've got some big ideas, but sadly we're not on launch date.
But an hour's up. And
an hour's up. So lots of you have probably got to go. Although we were told 90 minutes, but we felt we'd try and finish in an hour. We're available now to take any questions that you may have. If you want to, so really over to Janet and Paul and Kate and others from the Edge and Horizons group to
Thank you. That was just fantastic. That was just brilliant. There were so many different questions coming through. But before I go into anything, because we're out of time, I just wanted to quickly go over to the Twitter room and to the chat room. So over to Paul and over to Naomi, very quickly. Hi, Paul. Hi, Naomi. Are you there?
Hi, Janet. I'm here.
Yes. Anything from your side?
Not so much from Twitter, although Paul Chapman's commented on how giving people an anonymous, powerful voice really helped to encourage engagement, and we've seen comments about how patient voices came through strongly.
Yeah.
I've seen a few questions popping up on the chat room.
We've got some chat room questions, so I can go through those in a minute. I'll just let you finish through Twitter first.
Yeah,
well, I'll hand over to you, Paul.
Okay then. In which case,
Paul,
yes.
Paul, just before you talk about those routes, those other questions, the comment there mentioned by, was it Paul Chapman about anonymity?
Yeah.
We've A/B tested that as a process. So when people are given an anonymous voice in this environment, but knowing that they're not that if they say something that's inappropriate, we can find out who they are. So their voice is anonymised, but they're not completely anonymous if they were to be rude. We never find out who said whatever. That's not, we want to provide a nurturing environment. But that anonymity literally doubles the number of people who join, doubles the number of contributions, and in our view, doubles the quality of contributions too. It means that people's ideas are getting judged on their merit, not their author.
Important point. Thank you. Quickly over to you, Paul.
Okay then. I'll just give a very quick run through then. There was a definite resonation with the group where you were talking about the platform being simply a tool. The tool isn't a goal in itself. Having a nice shiny platform is not what you're aiming for. It's just the thing that enables you to get to where you want to go.
Exactly.
Yeah. Apparently the smaller professions who want to be heard, a lot of people seem to find that interesting, so it would appear that they want to be heard and people want to listen. So this is where those platforms you're talking about can give that, because you've got people who want to speak, there's people who want to listen to them, but they don't know how to connect as things stand. So these things that you're driving can help plug that gap.
Yeah.
Thank you for that, really powerful.
Yeah, and then the final conversational piece, which involved quite a few people on the chat, was about expanding on your question about how do we engage with those who are maybe less technologically savvy. And so there's quite a lot of chat about how we do that. So you might want to have a look through the chat after the event.
Yeah, we will. Just on that, Paul, very quickly. We at Clever Together, we run crowdsourcing processes for Devolution Greater Manchester, and we recently did a piece of work around, and you can check this out on a website called takingcharge.org.uk, where we used our platform, and we had 6,500 members of the public come and share their views on how people do or don't take charge of their own health and why. But we also connected up with the local Health Watch and local charities, and went into every single one of the localities and did face-to-face workshops and collected qualitative and quantitative data in face-to-face settings. And then when we analysed the two data sets, the online and offline, the really interesting thing was that the populations were very similar people. And by the way, these were what you call hard to reach people typically. So it's some of the older populations, ethnic minorities, etc. And their contributions qualitatively were not different from the qualitative contributions of those who joined online. So in that sense, we in that particular crowd, we validated that. But I think there is something that's got to be done more broadly within the NHS with these kinds of products. But we've had 1,900 people engage with this as a statistically representative sample size. You know, the voicing here, I think we can count as being pretty robust, especially because it was trying to so many other sources.
That's fantastic. Thank you so much. And I do need to wrap it up here. I'm really sorry because the conversation just seems to just be going the right direction, and everybody's getting involved now and asking the right questions. So I just want everybody to put their hands together and say thank you to Joanne and to Peter. You've just been fantastic. I've really enjoyed your session and I've learned lots. I've got so many questions buzzing in my head, but I do need to play host and to do my part here. I just want to introduce the next session, which is going to be coming up in January, and that's going to be on the 13th of January from 9:30 to 10:30, and it's going to be on DNA of care, and it's a team in NHS England, the staff experience team, and it's going to be held by Karen Deeney and Pip Hardy. So please, everybody join us, and thank you to everybody who's joined the Edge over the last year, and I wish you a very, very Merry Christmas, and I hope you have a fantastic holiday. So again, thank you so much to our presenters today, and goodbye, and have a good weekend. Bye bye, everyone.
Thank you very much.
Bye bye.